We just start our program. I request our eminent guest speaker, Dr. Malini Lawande. Madam, please share your screen and teach us.
Thank you. Let me just. Is my screen visible and am I audible?
Yeah.
Yes, ma'am.
Good evening, everyone. Thanks for this invite today. And over the next 15 minutes, what I'm going to do is talk about ankle MRI. And I think the most important thing when we talk about MRI is the resolution. It's very important to get good images with good spatial resolution. Otherwise, it's not possible to see the structures well. And here, there's something that I would like to emphasize for all of you. Ankle and foot MRI are not the same. So when we talk of ankle or hind foot, that MRI is different. When we are including midfoot and forefoot, the MRI, the planning, everything becomes different. So what happens is sometimes it's very confusing when the requisition just says foot. So more specific as to what area we are looking at. We usually start off with one scan with a large field of view, including the entire ankle and foot. But after that, we have to decrease the field of view and get these kind of images with usually a thickness of about 3 millimeter with 0 millimeter gap. So this resolution is very important. We usually acquire T2 FATSAT or STIR images like this, which show the marrow changes very well. And we acquire proton density images like this, which shows the cartilage very well as the ligaments and the tendon structures. A T1 weighted image also is acquired to look at the marrow. So that is about the sequences. Now we just look at the common pathologies and how do we try to assess them. So the most common indication for which we do ankle scans is injury, and we are looking at ligaments. So on MRI, all ligaments, all tendons, and all fibrocartilage are dark on all the sequences. This is because the collagen fibers are very tightly packed. So there's no place for the hydrogen protons to move around. So they don't give out any signal. As against that, if we look at, say, skeletal muscle like we can see here, or you can see this hyaline articular cartilage, that looks gray or intermediate signal intensity, because here the fibers are not so tightly packed. So tendons, like we can see here, the peroneal tendons, the flexor hallucis longus, and the ligaments look dark. So this is the anterior talofibular ligament, which we can see well in the inferior most sections where the lateral malleolus is almost ending. This is the posterior talofibular ligament, which normally has bit of a striated appearance like this, which is normal. The calcaneofibular ligament, we can see deep to the peroneal tendon. This here is the peroneal tendon, and deep to it, this is the calcaneofibular ligament. But calcaneofibular ligament is better appreciated on the corneal images. So corneal images, we start tracing it from its calcaneal attachment. Then you can see here the mid substance, and this is the peroneal tendon, just superficial to it. And here you can see the fibular attachment of the calcaneofibular ligament. Deltoid ligament, again, we see best on the corneal images, and then look at axial images also to corroborate what we are seeing. Again, fan-shaped insertion to the talus with striated appearance is normal. The tibio-talar component, which is what we are looking at most importantly. This here is the tibio-spring ligament. You can see again dark, seen well. This is the tibio-navicular ligament, much more anteriorly. But this is what we are assessing mainly in injuries, and that is the tibio-talar ligament, deep component, normally looks striated. If it looks homogeneous, something is not right. We need to look at the distal tibiofibular joint, and here you can see the anterior inferior tibiofibular ligament at a section where the talar dome is just about seen, and at the same level we have the posterior inferior tibiofibular ligament. So these non-fat saturated proton density images are very good, because fat acts like a normal contrast, showing these ligaments very well. On the corneal images, again, we can see the AITFL and we can see the PITFL very well. And this is the syndesmotic ligament. You can see here the distal portion of the interosseous membrane. So you can see all the ligaments very well on these images. Let's look at some pathologies. Here clearly you can see there is a near full thickness tear at the fibular attachment of the anterior talofibular ligament. Another example, and now we can see there's an almost full thickness tear of the ATFL from its talar attachment. Here we can see the entire anterior talofibular ligament, instead of looking dark, is now enlarged and showing hyperintense signal, bright signal. So when we say hyperintense or hypointense, we compare it to the skeletal muscle. Brighter than skeletal muscle is hyperintense and darker is hypointense. And this here is the calcaneofibular ligament, the fibular attachment, which also shows similar findings. So this was not completely disrupted, but this is a partial thickness injury. We can also identify avulsion fractures. You can see here the avulsion fracture of the fibular attachment of the ATFL. Again, we can see the osseous fragment very well. So again, fat saturated images make everything look dark with bright edema and hemorrhage. We need to correlate it with these non-fat saturated images to identify these small osseous fragments. Deltoid ligament injury, we can see here, we saw the normal deltoid ligament more like a fan-shaped structure with striated appearance. But here you can see there is disruption and the fibers are torn. We need to look for the distal tibiofibular joint injury to distinguish low ankle from a high ankle sprain. And here we can see just where the talar dome is yet to start. And you can see the anterior inferior tibiofibular ligament. High grade injury can be seen. Same patient also had deltoid ligament injury. These are the normal fibers which look striated, while these fibers you can see show bright signal, more homogeneous. So there's a partial thickness injury. The same patient also had syndesmotic ligament injury. You can see there is disruption of the fibers towards the tibial attachment. MR can also play a very important role to look for occult fractures like anterior calcaneal process, lateral talar process, sometimes non-displaced fifth metatarsal or cuboid fractures, which may be missed on radiograph. MR will also show you these marrow contusions, marrow edema, so significant marrow edema, and there is an ATFL injury. Patients with chronic injury, MR has an important role to play because in chronic injury patients, we can look at the articular cartilage. So here in this patient, where we can see the anterior talofibular ligament shows remodeling changes. It does not look completely dark and smooth as we saw earlier, but some continuity is maintained, so it's partially remodeled. But what we also see is, if we look at the cartilage of the talus, there is cartilage loss here along the medial talar dome with subchondral cystic change and marrow edema, that is osteochondral lesion, which later may progress to fragmentation. So clearly we can see that this fragment has completely separated the medial talar dome, but is still in situ, has not become a loose body, and lot of marrow edema around it. So chronic instability, MR can show you the cartilage status also very well. Having looked at the ligaments, the next most common indication that we see are the tendon pathologies, tendo-Achilles pathologies being the most common. And what we see is in patients with pain, here you can see this patient has a Haglund deformity, osseous prominence here. There's marrow edema around it, retrocalcaneal bursal fluid here, and we can see the Achilles tendon shows a undersurface tear. So this is the length of the tear that can be measured and shown well. The bumps, so the triad of findings, all of them are seen in this case. We can see non-insertional tears, and we can talk about the exact gap between the torn tendon, the length of the distal stump, the condition of the tendon, whether it is degenerated or not. Ultrasound can also play an equally important role in assessing Achilles tendon because it's a superficial structure. So ultrasound would also be performed, but the marrow edema part would be seen well on MR only. Another very common what we see is women presenting with acquired flat foot, and then what we see is tibialis posterior tendon dysfunction. This is the FHL, this is the FDL, and this is the tibialis posterior. So normally tibialis posterior is about 1.5 times the size of the adjoining FDL. Here it is much more larger, showing bright signal tendinosis, and you can see a split tear is developing inside it. So there is moderate tendinosis with a longitudinal split tear and tendon sheath fluid and edema. So tibialis posterior tendon dysfunction, and that could later lead to lateral hindfoot impingement, subfibular impingement, and all of that can be shown very well on MR images. Peroneal tendon pathologies also can be demonstrated well. Like for example here, this peroneus brevis here almost has a boomerang-like appearance encasing the peroneus longus. And on these sagittal images, this is the peroneus longus, which is normal. And you can see a partial thickness tear of the peroneus brevis in its retro and inframalleolar extent. You may have longitudinal split tear of peroneus brevis into which the peroneus longus might herniate. We can have peroneal tendon dislocation. Here you can see the peroneal tendon, instead of being present in the peroneal groove, is dislocated laterally, and we can assess the peroneal retinaculum, whether it is intact or torn also at the same time. A common cause of heel pain being plantar fasciitis, and what the information that MR can provide or add is, here you can see thickened plantar fascia, a spur, and marrow edema. So this marrow edema suggesting that rest may be needed before much of rehab can be done. And there is some small undersurface tear. Sometimes you can have a higher grade tear too. Corneal, these are the sagittal images. Corneal images show very well the medial central band of plantar fascia, while the lateral band is intact, central band here, and the medial band is showing plantar fasciitis. This can cause Baxter's neuropathy, and MR can demonstrate abductor digiti minimi, sometimes the flexor digitorum brevis or quadratus plantae muscle atrophy or denervation changes. The last thing that I would like to speak about is turf toe. And again, just to emphasize, this kind of imaging is possible only if we acquire high resolution, low field of view image. If I acquire the entire foot MRI images, there's no way I'll be able to talk about plantar plate or the articular cartilage or the small ligaments in the toe. So we need to be very clear about what we are looking for so that the scan can be planned accordingly. So when I acquire high resolution images for just the forefoot only or the great toe, you can see this kind of resolution, and you can see here, this is the plantar plate here. This is the FHL tendon. These here are the hallux sesamoids. This is the intersesamoid ligament, this bit, and then is the FHL tendon. As you come, this is the midline. As you come more laterally, this is the sesamoid phalangeal ligament. So you have the medial and the lateral ones. They can be traced very well. This is the collateral ligament, and this is the accessory collateral ligament. So all of these structures can be identified very well, but with the right high resolution images. If I do a whole foot scan, I'll not be able to talk about these structures. So showing example, here you can see the plantar plate is not visualized at all. It is completely torn at its distal attachment. And the sesamoid also had migrated more proximally. You don't see any plantar plate at all. Another example, again, you can see plantar plate injury. This is the FHL. This section is somewhere slightly beyond the sesamoid. Sesamoid is here, it is at this level. So this is the normal lateral sesamoid phalangeal, and you can see the medial sesamoid phalangeal ligament showed a high-grade injury. So we need to look at all the planes, high-resolution images, and there was a lot of subacute edema in that location. And here, in this patient, we can see a small fracture. There's an avulsion fracture at the attachment of the medial sesamoid phalangeal ligament at that point. So this is here the plantar plate injury, and this was the lateral sesamoid phalangeal ligament, which is intact, like we can see here, while medially there is a small avulsion fracture. So all of this is possible if we have, one, we know what we are looking for, what is being suspected clinically, plan the scan accordingly, and then look at those specific structures. So to summarize, I would say that high-resolution images are extremely important. Ankle and foot scans are different, so it would really help us radiologists if you specify what you're looking for, which part of the foot, hindfoot, midfoot, forefoot. We do start with a large field of view scan covering the entire foot with one stir image to just have an overall view, what is happening, is there some other pathology somewhere else. But after that initial scan, we would like to reduce the field of view, look at specific structures in better detail, and choosing the right sequences to be able to look at the pathologies better. Thank you so much. Any questions, I would be happy to answer.
Thank you, ma'am. Nice talk indeed. Before we going to our next speaker with the pathology, if there is any question from any one of our listener, please send your question. Madam is here. So I request Dr. Rajiv sir, if he is in the queue. Sir, please.
Yeah. Ma'am, excellent talk as usual. Actually, the problem we face is to differentiate between acute Charcot and infection. So can you give us tips on to identifying that with MR?
So sometimes it can get difficult on MR also, but the usual things which we follow are, one, if we are seeing any sinus or collection which is communicating with the bone, obviously it's very easy to say that it is osteomyelitis. Also the T1 signal intensity. So the T1, the bone on stir, both Charcot as well as infection will look bright, but on T1 weighted images, the infection looks much more dark or hypointense, while Charcot doesn't look that dark. So that can give a clue. We can use diffusion weighted images because infection can show restricted diffusion, while Charcot usually would not. So putting these things together, extraosseous collections communicating with the bone, T1 dark signal, and restricted diffusion, we can differentiate between the two most of the times. But having said that, yes, there are certain times when it's really difficult, or it could be that the patient has Charcot and then superimposed infection also is there.
Thank you.
There is another question from Dr. Gandhi.
Hi, ma'am.
Yeah.
Good evening. Ma'am, what would be the ideal time to assess these kind of injuries post-trauma? I think if it is recent trauma, it might be difficult to assess. But what would be the ideal latest?
So frankly, there is no ideal time in that sense. Only thing that we need to keep in mind is in acute injuries, MR may overestimate the injury a bit because of all the edema and hemorrhage. But at the same time, once it is chronic, then MR may at times underestimate, because what happens, the ligaments remodel. And we are on MR looking at ligament continuity. If it looks continuous, we say that it's intact. But functionally, it may be lax, which is possible only on the dynamic clinical examination or stress radiographs. So there's no ideal time really. Just that when we are evaluating in acute conditions, we know that we might be slightly overestimating, But having said that, if I see a full thickness tear, it is a full thickness tear.
Okay.
And chronic, we may underestimate.
Thank you.
Okay. So next we are moved to next session. Dr. Thomas with us. Before that, we will ask our previous month two speaker, Dr. Krishna Prasad and Dr. 𝐷𝐲𝐻 Saha. So we just handed over their certificate from this platform. So Krishna Prasad, your certificate is here.
Thank you, sir.
And I just ask our office, please. Professor Panchbhavi, sir. Yeah. So this is to our Krishna Prasad. Thank you, Krishna Prasad.
Thank
And
you.
we already get your letter to editor. So definitely we will make it and send it to the editor with that comments, what you already shared. And the next certificate present to Dr. 𝐷𝐲𝐻 Saha. Thank you,
Thank you so
𝐷𝐲𝐻.
much.
Thank you. But your write-up is pending still. So please.
Sir, by this week for sure.
Yeah. So I would request next speaker.
Abhijit,
Yes,
there
sir.
are one or two questions. Can we
Yes,
take
sir.
those questions before ma'am leaves?
Okay. Yes, sir.
Yeah. Who has raised the hand? I think
Aditya.
Aditya.
You are
You're
muted,
muted.
Aditya. Please. Yeah. Unmute yourself.
Hi, ma'am. Good evening. Yeah. So I want to know about, sometimes we come across acute spring ligament injuries. So what is the best sequence or best cut to see the spring ligament injuries?
So spring ligament can be seen very well on the coronal images and the axial images. And sequences on MR, it's not any one sequence. So we need proton density as well as fat sati, both of them. But the coronal images show you the spring ligament extremely well, and we corroborate it on the axial images.
Okay. So do you think that the correlation with the tibialis posterior and spring ligament is important for assessing the spring ligament injury? Sometimes
Yes.
the spring ligament comes closer to the
Yes. So
tibialis
that's how, in fact, we on the axial images, we localize spring ligament by identifying the tibialis posterior tendon and looking medial to it.
Right. Okay. Thank you.
Yes, sir, I have a question, sir.
Yeah.
Hi, ma'am. Good evening. Do you have any specific position that you recommend for foot and ankle MR? Like
The position. Yeah. So position, normally it should not be too much plantar flexed. What happens if it's more plantar flexed the foot, then the anatomy gets distorted. So we would like it to be in kind of neutral or maybe little, not very dorsiflex, but neutral position. Other than that, there's no specific position. Sometimes, like in the peroneal tendon dislocation that I showed you, in fact, the patient said he could feel some kind of snapping thing in certain position. Routine MR, we didn't see anything. Then we made him that particular position of the ankle and we could see the peroneal tendon popping out. So that ultrasound becomes easy, dynamic that than on MR, but otherwise that's the position that we do. And unless Morton's neuroma, sometimes you may want to do prone imaging. But that also with high resolution, we don't really need to. Routine imaging helps us.
Thank you.
Thank you, ma'am. So we are going to start our next session. If there is any question, please write up. Please write up.
Okay.
So I will request Dr. Thomas Rees, please share your screen.
Thank you, ma'am.
Thank you, ma'am. Thank you very much.
Thank you very much, ma'am.
Good evening. Right then. Is my screen sharing?
Yeah, please.
Excellent.
Yeah.
Thank you all for inviting me to speak at your academic session this evening. I'm going to be following on from Dr. Malani's excellent presentation. As foot and ankle surgeons, you'll be very familiar with the breadth of conditions and pathologies which can occur in this small part of the body. It's no different to us as radiologists. So for this evening's presentation, most of my cases is going to involve the adolescent or young ankle covering trauma and trauma mimics, mainly at the ankle and around the talonavicular and calcaneal cuboid joint, which I think will mix in quite well with the talk we've just had, who's covered everything else, it seems. So should be good. So just a background myself, I'm a radiologist in the University Hospital of Wales in Cardiff. That's my picture up there because I don't have a webcam. I've just returned from a couple of years in New Zealand to work for my fellowship and a year's consultants there. Now, I worked in the private healthcare system in New Zealand, where access to private healthcare is completely, is very, very easy compared to the UK. And as a result, we had lovely images. So all of my, so I'm going to be going through case images today. Well, I'm going to be going through cases with you this evening, live from PACS. Now, I don't know, from my experience in different countries, different cultures have different attitudes to whether they review scans or just read the reports. I'm not quite sure what the culture is with India, so I hope I've pitched this at the right level for you, okay? So starting with the first patient, this is a young patient who's presented with possible ankle impingement. And just to go through the sequences we used in New Zealand is we'd have a proton density, non-fat sat and fat saturated, and coronal PD fat sat, coronal PD, and then occasionally we do T1 PD and PD fat sat sagittal images. And as I say, this is all on the 3T. We'll have seen from our previous talk that the sequences you use are very different. Sort of in Wales, our fat saturated sequence here is a T2, which I don't quite like as much, and our coronal is a fat sat, which makes the CFL ligament quite difficult to see. So I'll just run through how I tend to go through an ankle. Initially, I tend to evaluate the syndesmotic ligaments anteriorly and posteriorly before moving forward to the ATFL, which should look nice and thin like this. You can evaluate the CFL. You can sometimes see the CFL going between the calcaneus and the peroneal tendons on both fat sat and non-fat sat image. And then you get the PTFL at the back. As we know from the previous talk, our deep deltoid ligament should be nicely striated. And then as we get medially then, we should be able to see a band-like structure beneath the tibialis posterior. And alluding to our previous question, this is our spring ligament, which looks nice and intact here. We get good views of all these ligaments on the coronal. Here's the syndesmotic ligament anteriorly and posteriorly. And then we've also got the PTFL at the back here and ATFL coming in at the front. And we see CFL creeping underneath the peroneal tendons. In terms of our spring ligament, this has 3 components, and the coronal is the best, is a great way to see it. And you see this sort of C-shaped structure here, deep to the tibialis posterior tendon, and this is all 3 components. So you've got, and the superior medial band here being the most important. And then finally, we finish with sagittal images. And then the abnormality here is that we've got a os trigonum, so an accessory ossicle here, which has got some bone marrow edema associated with it and in the adjacent calcaneus. So this patient has got os trigonum syndrome or posterior ankle impingement. Moving on to the next case. Next case now is going to be focused on the lateral side of the ankle. So midfoot pain for 2 months following a fall. So again, starting with the axial images, we can see that the syndesmotic ligaments are okay. The lateral ligaments look good, as do the medial ligaments. But as we come through here, there's an abnormality centered on the calcaneal cuboid joint with some edema going into the EDB muscle. And we've got some bone marrow edema as well. Initially, whenever I see this sort of pattern of injury, I'm jumping straight to the talonavicular joint, and I can see that the dorsal talonavicular joint is thickened. It's high signal on both the PD and the PD fat sat, with a tiny fragment of bone, from the dorsal talus, in keeping with a little avulsion fracture. As we move then slightly more laterally, we've got the bifurcate ligament, and again, here is the navicular branch of the of that ligament, which is intact, but we've just got edema in the cuboid component here, and then we scroll then through to the lateral margin of the calcaneal-cuboid joint, where we've got a dorsal calcaneal-cuboid injury and probable previous avulsion. So this pattern of injury is consistent with a Chopard injury to the talonavicular and calcaneal-cuboid joints, and whenever we see these, we send this your way pretty promptly to make sure nothing more sinister happens. So next patient is a slightly older patient who's presented with perineal instability. And we can see here there's an abnormally thickened tendon, and there's an almost C shape of another tendon around this tendon. And usually the initial thought process here is this is a peroneus brevis tendon, with a split tin, invagination of the peroneus longus. But however, this case is not quite the same, because we can see the peroneus brevis tendon forming this C-shaped structure which wraps the other tendon. So this must be in fact the peroneus longus tendon, and we can normally follow it underneath the arch of the foot here into the medial side, and we're missing that. So again, can corroborate your findings with the coronal, and we can see one of the tendons here going into the base of the fifth metatarsal. So this must be the brevis, and then we'd expect to see the longus come along here into the medial cuneiform, and we're just seeing intermediate structure here, not a tendinous structure, and this is the avulsed component here. So this is a peroneus longus tear, and incidentally, there's a bit of an osteochondral lesion up here. I hope I'm going through this at an okay speed for you. I've got a few cases to go through, so I'd like to be able to show you them all. So this is a young person who has a netball inversion injury, and they're wondering whether there's a syndesmotic tear. So we can see here that the syndesmotic ligaments are both intact. However, just below this, we've got a large amount of joint fluid, and we can see a thickened, hyperintense ATFL, which is not in continuity. So we have a high-grade tear here. And then we're also seeing a lot of bone marrow edema in the talus, with we can still see the striations within the deltoid, but this hyperintense, there's been a contusion to the deltoid ligament there. Again, you can sometimes cast an eye on the CFL here, and I get the impression it's thickened there, but I'll confirm that shortly. And then we've got this high signal abnormality in the calcaneus, which is unexpected, and we'll have to figure out what that is. So just to focus on our ligaments, so at the back, we've got the posterior syndesmotic, at the front, anterior syndesmotic. Both of these look good. However, we've got this thickened, hyperintense material here in the expected region of the ATFL and keeping the tear. And also the CFL, which you saw beautifully on previous pictures, is thickened and hyperintense and keeping with a tear. But our PTFL looks pretty good and is usually the last ligament to be torn. And then we come across to our unexpected finding of a lesion in the calcaneus. And whenever we get these, it's good to get a T1. So we can see in this that they've got some low signal areas which we worry about, but at the periphery we've got high T1, which demonstrates some fat suppression. So it's low signal in the fat suppressed images. So this is a fatty entity which has got some cystic spaces and edema, in keeping with some cystic change or necrosis, and some granulation. So that's the incidental finding. We've got ATFL, CFL, and deltoid injuries, along with perineal tendon tenosynovitis, likely secondary to trauma, which we can, appreciate in all planes, a bit of edema along the perineal tendons. Also, just to note, the bone lesion was unexpected, but this patient's also got an accessory soleus muscle going all the way down into the calcanea. So always have to be prepared for unexpected findings, such as altered anatomy or bone lesions. All right, then. I don't see too many of these cases. So a 16-year-old French rugby student playing rugby in New Zealand has come in with lateral ankle pain after a rugby injury, and we can just see here good going thickening and hyperintensity of the anterior syndesmotic ligament, also of the posterior syndesmotic ligament, in keeping with a high-grade syndesmotic injury. ATFL doesn't look too bad and looks intact. And for some reason, we have a PD fat sat here, but the CFL is also intact. We've got bone contusions of the medial malleolus, but this deltoid still has that beautiful striated appearance. And we can also see the spring ligament here underneath the tib post, which is intact. Here, so that is this case. He's also got an incidental Stieda process, which can cause problems, but it doesn't seem to be doing so here. The other abnormality here is there's a little, very difficult to see on the MRI, but there's a little osteochondral fragment here, which has come off from the back from the posterior malleolus, and this is visible on the X-ray, which I don't have to. Oh, I do have it to hand actually. There is a. It doesn't want to be hit. There we go. Is it going to come? There we go. So always, the other lesson is always look at your X-rays, just because we've got a clear abnormality in the X-ray, which is really subtle to see on the MRI, unless you go looking for it, and then you can find the the donor site, which is the posterior malleolus just here. Right then. So starting to move from the lateral to the medial side now. So this is a patient who's had 2 months of ankle pain after running. So as we go through this study, we can see there's a lot of edema in the foot and ankle. A lot of edema in the foot and ankle with joint effusion. The syndesmosis is intact. Now, going back to our earlier talk, we can see that the ATFL is in continuity. It's intact here, but it just looks a little bit thickened. And when we look at the CFL then as well, this is also thickened, but in continuity. So the findings, these two findings make me think that this patient's had a previous ankle ligament injury of the ATFL and CFL. And then just like our initial case, there's some hyperintensity and thickening of the Chopard ligament, a calcaneal cuboid joint effusion with bone marrow edema at the dorsal calcaneal cuboid joint. So again, this is another case of a Chopard injury with injury to the bifurcate as well. And then in terms of looking at your, this might be a good time to mention about looking at the lateral ankle ligaments. Sagittal is often a really nice way to have a look at it. If you scan in and out like this, we can see the ATFL running forward a bit like a V shape. You've got the front part of the V is your ATFL, the back part of your V is the PTFL, and we can sometimes catch a glimpse of the CFL just going underneath the perineal tendons, which is this black structure here. whilst we're on the laterals as well, on the sagittals, we can also get a glimpse of the syndesmotic ligament at the front here as well. So you can use all three planes to help you troubleshoot and come up with your diagnosis. And then, as I say, we're moving now to the medial side of the ankle. So this is the spring ligament again, and there's some hyperintensity in the supramedial band here. So this, and which is also somewhat hyperintense on the sagittal and coronal. So we've got a partial tear there. Right then. So as I say, we're going to move over to the medial side now. So this is a patient, a young patient who has got, 40-year-old patient who's got flat-footed and tibialis posterior tendinopathy. And as you know, as expected with the history, we've got a tibialis posterior tendon sheath effusion. Although the effusion itself doesn't look too bad in itself. What we do have, however, is thickening and hyperintensity centered around these two deep structures here. And if I can just get the coronal out. So here we've got our deep deltoid ligament. And then as we come forward, we get the tibio spring, and you can see it here is all thickened and hyperintense, and it sort of continues into the spring ligament just here, which correlates to the hyperintensity on the axials, and we can almost certainly see it also on the it's harder to see on the sagittals, but here's some hyperintensity here of the spring. So this patient's got tibialis posterior tenosynovitis with a partial tear of her spring ligament, and this lady may well be heading towards tibialis posterior dysfunction. Interestingly, she's I'd never heard of this before I went to my fellowship, but this patient's got a fair bit of fluid around the ankle, but this is a Ghibelli's bursa, so need to control myself not to get too excited and call these talonavicular joint effusions, although there is a small little, so that's the Ghibelli's bursa there. So this next patient is an 11-year-old kid who's come in with a query of Taylor coalition with pes planus. Now then, looking through the images here, there's no evidence of coalition here. We can't see any bony bridging, can't see any cortical irregularities suggest any fibrous coalition. But what is quite evident on her MRI is that the so we've got the tibialis posterior tendon here, which then goes into this ossicle, which is hyperintense. There's also hyperintensity in the medial aspect of the navicular and fluid between both of these components. So what we've got here is a type 2 os naviculare with fluid in the synchondrosis, and the tibialis posterior is attaching to this. So we've got a synchondritis due to a accessory navicular, which is a type 2, which is the cause of her, medial pain. She then had to follow up, and I'm not aware of any intervention, but a year or so down the line, she's had a subsequent MRI, and all the edema is settled. So they've not had to chop anything out. It's just settled in due course. Whilst I've got these pictures up, I'm just going to show you the the normal appearance of a Lisfranc ligament here. So let me see if I can. So the Lisfranc ligament lives here. So we've got three components to this. Obviously, we've got the dorsal interosseous, which is the main component centrally running between the medial cuneiform and base of the second metatarsal. And then we've also got a broad plantar component here. We can see all these are intact. And I'll come back and compare this later. This is the normal appearance on axial imaging, and we get a good look of this frequently on MRI. Right then. So sticking with medial, on the medial side of the ankle. So again, here we're seeing a hyperintense deltoid ligament. So in keeping with a contusion. Now we're also seeing some bone marrow edema and some cystic change in the head of the talus. And when we look at this on the MRI, we can see an osteochondral abnormality here with bone marrow edema within the osteochondral lesion. We've got a difficult to see fissure at the posterior margin of the osteochondral lesion. And we seem to have a rim of fluid here going all the way, undermining the entire osteochondral lesion, which is highly concerning for a unstable lesion. However, when we evaluate this in a bit more detail on the coronal, we can just see that this apparent fluid signal is actually a number of subcortical subchondral cysts. And whilst these are features of instability, having subchondral cysts and edema, it's less of a risk factor compared to frank undermining fluid cleft. Excellent. Heading towards the end now. I've got 3 cases to go. So this is a patient who's in their 20s and has inverted their ankle. And the question is whether they've got a body as a result of this X-ray. So we can see here the talar dome looks nice and congruent. No other abnormality of the ankle joint, but on the X-ray we've got this calcific abnormality at the anterior margin of the joint. And as soon as we sort of go through the axials, we can see an abnormality at the anterior aspect of the joint, which correlates lovely with the radiographic abnormality. However, as we scan through as we look through the ankle joint itself, the ankle is articular cartilage looks pretty congruent with no big osteochondral defects. So the next challenge is to figure out where this has come from. And again, when you assess in all 3 planes, there's a very subtle osteochondral lesion from the anterior aspect of the tibial plafond. It's, not the most common location to see this, or to get this injury. So it's just important whenever you see something like this to figure out where's the donor site, and more often than not, you will find one. Right then, penultimate case. So it'd be difficult for me not to do this talk without speaking about the Lisfranc ligaments, because it's the one injury we all loathe to miss. And we're certainly taught this as radiology registrars. So again, whilst this is a midfoot, dedicated midfoot study, we often get these images on our ankle MRIs, and we can see some hyperintensity and thickening of the interosseous portion, the central portion of this Lisfranc ligament. So we know straight away that this is torn. And as we come through then to the coronals, if we compare it to the case 2 or 3 ago, we've got a really ill-defined, thickened, hyperintense interosseous component. We should have a nice thin black line here, but we've just got a grey mush on the dorsal component. And then similarly, it's often quite hard to see the plantar component, but we're seeing it really well here because it's hyperintense and also thickened. So this patient's got a high-grade tear involving all 3 components of the Lisfranc ligament. The other thing to note about the midfoot is that you've got capsular ligaments connecting pretty much each metatarsal. So, that this is another area we tend to look at. So this is not the plantar Lisfranc ligament. This is just a plantar capsular ligament between the 3rd and 4th metatarsals. I don't tend to find the sagittals all that useful for looking at the Lisfranc ligament. And finally, this case is to hopefully summarize our talk. This case has got everything. So we have got here a high-grade ATFL tear, which is accompanied by a thickened hyperintense CFL. So we've got a CFL tear as well. Thankfully, the PTFL and the syntesmotic ligaments are intact. We've got invagination of the peroneus longus into the peroneus brevis with a split tear of the peroneus longus, often best appreciated on coronal. This is something I loathe to overcall because I think it's very easy to, it is quite easy to overcall these, but there's a little tear in there which we can see. Additionally, on the medial side of the ankle, we've got hyperintensity here. The fibrillations aren't quite as clear as previously. So we've got a deep deltoid tear. And then just to wrap things up, our spring ligament here is thickened. It's a bit hyperintense. So we've also got a spring ligament injury to boot as well. And then just to finish as we started, there's a bit of evidence of a Chopin injury as well with the bone marrow edema, the lateral aspect of the calcaneal-cuboid joint. Here, a thickened dorsal calcaneal ligament and injury to the cuboid limb of the bifurcate. And there's also some thickening of the dorsal talonavicular ligament. So a nice case to hopefully recap everything almost all in one. That's the end of my talk. I hope it's been useful to you. Thank you.
Yeah, thank you, Riz. It is really a nice talk. Now it is open to ask the question for everyone. There is one queries I can see. And the question is that for Riz, how common is asymptomatic osteochondral defect or edema in talar head? So Riz,
could you repeat that question? Sorry.
How common is asymptomatic osteochondral defect or edema in talar head? Is it common?
Are you is this in relation to osteochondral defects or the osnavicular? And sorry, how often are they symptomatic? Well, I'm not sure if I'm the right person to ask that. They often, a lot of these patients walk into our scanner and they walk out without seeing a radiologist who's hiding in the dark somewhere. So I'd probably have to pass that on to our radiographers. But obviously, a lot of patients are coming in for imaging in the context of ongoing ankle pain. And a lot of patients won't have any of the findings other than the osteochondral lesion with bone marrow edema. So I can only infer from that they are symptomatic with it. But that's the anecdotal experience I've got, to be honest.
Okay. So Dr. Dureja, sir, please sum up this.
I think both the speakers have done a wonderful job in explaining the intricacies of looking at MRI, foot and ankle. And I thank both of them from my heart and from all the IFAS members who have really got enriched by the knowledge given to them in these two deliberations. We will, of course, pass on a few more questions if anybody is coming. And with that, if there are no more questions, and I think, Abhijit, we can
conclude it.
Conclude the session.
Yeah. Rajiv, sir.
Well, I think 2 points from my side. Number one, quite often I've seen that people get an MRI without getting the thorough history, clinical evaluation. MRI is a magnified imaging of so many things which are asymptomatic. So the first and foremost thing should be thorough history and clinical evaluation, which narrows down you to the points which you want to see in the MRI. So that's one thing. And second thing, wherever a tendon would turn around the bone acutely, these are the areas where what you see in MRI is something called magical effect. And this magic ankle effect will not give you tear, would not show tear of a tendon in the MR. And that's where you might have to go to a dynamic ultrasonography where you can invert, where you can evert, you can dorsiflex, plantarflex, and look at this kind of the tear. So not to get the surprises. These were 2 points.
Okay.
That's a very valid point about the magic angle artifact. We can sort of see it here, and I didn't touch upon it in my talk. Sort of the PD sequence is quite prone to it at around, well, I think it's about 50, 53 or 47 degrees, which is roughly what we've got here. And you can just see sort of when the peroneal tendon just goes at this sort of angle, it starts to become hyper intense, and that's where we get difficulty on PD FATSAT to see whether this is real brightness or an artifact. And one of the reasons we do a T2 FATSAT in our institution in Cardiff is to minimize this artifact so we can be a bit more definitive whenever we call it.
Okay. Any question? Aditya, do you have any question? Yeah, we will conclude. This is the last. You are on mute. Please unmute. Please unmute. No, you are on mute. Please unmute.
Yeah. How do you evaluate tarsal tunnel in MRI? I mean, what is the value of MRI when, I mean, apart from ganglion cysts and all, can we evaluate nerve thickening and all in the MRI?
Yes, we can get a reasonable idea of what's going on in the tarsal tunnel. So obviously we've got a neurovascular bundle between, we've got tibialis posterior, FDL, FHL, and it's sat here between FDL and FHL. And you know, we can get reasonably, you know, we can see there's no mass lesion here in the tarsal tunnel, but you can actually see the neurovascular bundles all separating to the various branches here. So we get you know, particularly on our 3T scanners, which can give us some lovely pictures, we can get good imaging just off these. However, you can also do dedicated MRI neurography, whereby the sequences that they use will suppress high signal within blood vessels, so that the only high signal left in the neurovascular bundle is the nerve. And so then you can see whether the nerve is more hyperintense or more thickened at any one point along its course, and that can give you a more specific answer. But you know, you can rule out compressive lesions certainly with this kind of MR, and anything gross in the nerves. But something subtle that's neural might be a bit bit harder to sort of identify.
So other thing question is regarding interdigital neuroma. So is it clearly visible in MRI? I mean, how is you, or do you do an ultrasound for that?
So in our institution in Cardiff, we routinely do ultrasound to figure this out. I did have a case of this which I thought about discussing, but I didn't want to go too far. So I have I didn't put it in. There we go. If you can give me a second, I can hopefully show you a Morton's if you want. I have found the case. Can you give me a second?
Sure.
So in my experience, the important thing when it comes to Morton's neuroma is having a good good quality. I'm just going to change this around slightly. Sorry. is having a good quality T1 non-saturated sequence. So so let's start with this intermetatarsal space here between 2 and 3. The neurovascular bundle is going to be here, and I suspect that is the nerve just below my mouse, and you can see it starting to separate and go up into each toe. So it's around there, it's around there. That's the digital nerve. Now, in the next one across, so this is the digital nerve here, and we've just got this focal thickening in the intermetatarsal space, and then that sort of then continues then as the interdigital nerve. And when we look at the PD FATSAT coronal, we can see there's a little bit of fluid in the bursa here, which is this part here, but the thickening that we're seeing is also here, but that's not fluid there. So this is, to my eye, this is a perineural fibroma, perineural fibrosis, sorry. So a Morton's neuroma of the interdigital nerve with a small amount of bursal fluid. But again, high quality, much like the previous talk, high quality, small field of view. Imaging is essential here with a specific question, so we can hopefully do the best test that will give you an answer if you haven't got one on ultrasound. Right then, thank you ever so much for having me. I'm going to log off now. Thank you.
Thank you.
Kamal Duneja sir, so we will conclude.
Yeah, both the speakers have done wonderful job. I think Reese is already logged up, and Dr. Malini also gave a wonderful talk.
Yeah.
So I hope
Professor Panchvavi is there. I think
everybody is liking this effort which Abhijit is putting to organize these journal clubs.
Yeah, it is Team IFA's effort.
Yeah. So how much is the attendance in the last
44.
44. I feel it's low. I mean, we expect more people to join it,
Yeah, yes, we think.
Maybe the tempo is building up and people are liking it, and anybody who joins is generally there for the next channel club. So that's how the number is increasing. Yeah.
Yes, we hope so, sir.
Yeah. Yeah. Right. Thank you.
So,
everybody.
yeah. Good night, everybody. Good night, everybody.
Thank you, sir. Thank you. Good night.
Thank you.